Hi, everyone. I'm Chad Cook. I'm with the Center of Excellence in Manual and Manipulative Therapy at Duke University, and very pleased to have Mike Bade here today, Dr. Mike Bade, who recently was a senior author on a paper titled Multimodal Conservative Management of Arthrofibrosis After Total Knee Arthroplasty Compared to Manipulation Under Anesthesia, a feasibility study with retrospective cohort comparison, which was published in BMC Pilot and Feasibility Studies just this year in 2022. And by the way, the paper is open access. So Mike, we go back a long way. Do you mind telling us a little bit about yourself, your current role, and your research interests?
Yeah. So currently I'm an associate professor at the University of Colorado Anschutz Medical Campus. And I had the privilege of teaching in our DPT program. I head up our clinical reasoning track, so a lot of the evidence-based practice series here. I'm in charge of our track here, as well as I teach in our rehabilitation science and PhD program and mentor PhD students and postdocs within that program. And I have an active research agenda focusing on older adults, and specifically the area that within our lab. So I work as a part of a large team called the Restore team. And our overall mission and vision is to really improve health and quality of life for older adults. And so I head up a lot of our orthopedic lines focused on osteoarthritis and joint replacement.
Yeah, I know your Restore team is very successful, along with a lot of the research you all do there. So the study I want to talk about today is the one in which you investigated arthrofibrosis. So can you give me the background reason why you targeted that research question?
Yeah. I have a training in manual therapy. I was the proud first fellow of the Duke Orthopedic Manual Physical Therapy Fellowship under your mentorship, and that's how far back we go. And I was also past director of Regis University's Orthopedic Manual Physical Therapist, and I've always been passionate about manual therapy and how these techniques can be utilized to help patients. And if there's a tough patient population out there, one that I've always been interested in ever since I was a DPT student. I can remember in 2005 on my final clinical rotation, I went to University of North Carolina, Chapel Hill. I remember we had an individual who had joint replacement and was suffering from arthrofibrosis. And my CI at the time, he'd literally help, he'd ask me to come into a private treatment room with this individual he was about a 50-year-old man, father of two, and very, very nice guy, and just having a really hard time getting his range of motion. And my job as a student PT was to essentially kind of hold him down on the table while he bit on a towel. And my CI cranked on his leg for a good 30 minutes. And this poor man tried not to cry very hard, right? And it was just tragic. And I was like, this is what PT is, and this is how we help these people. And then I'd see him later at the store that day, limping around, barely using his knee because he's just in so much pain from the treatment that day. And it's like, well, we got to help him push through the pain. And that's kind of the mentality that I still see actually practiced by a lot of clinicians today. It's like, hey, if I can just break up that scar tissue with my hands-on techniques, he's going to be better off. And sure, it might hurt a little bit in the short term, but we're going to make progress. And unfortunately, I didn't see that with that patient. He definitely did not make progress and had an awful outcome. That's how I describe that. And as I've done a lot of research in total knee arthroplasty, I've had the privilege of seeing hundreds of patients after that surgery. I like that surgery because it's the #1 most common orthopedic surgery performed. We do a ton of them. And I think this patient population has a lot of need in terms of rehabilitation, a lot of unmet need personally. But within the context of our trials, we'd often have, one or two, like if you're running a 100-person trial, there's definitely going to be a couple people who come through who develop arthrofibrosis. And the big question is, what do you do with these people? And so, throughout, I just kind of had the fortune of being in a spot with funding where I could take a look at this as like a pet project question. It was an unfunded project, with the eye being like, could we potentially start a line of investigation into this area? And so this was kind of our first foray into specializing into this patient population of individuals who are really struggling with the recovery and are given the label of arthrofibrosis.
So I think I mentioned offline, my father had a total joint replacement in his 70s, and he got arthrofibrosis. And just what you described with your 50-year-old patient, they just beat the tar out of him for months upon end, and he developed high impact chronic pain. So can you define arthrofibrosis for everyone, just to make sure that everybody's on the same page?
Yeah, it's a little bit of a catch-all condition in some ways. You know, like they actually had an international panel of medical experts to define this, and they arrived on the definition of its restricted range of motion, either in flexion or extension, that's not attributable to something like a poorly positioned implant, infection. They often say like complex regional pain syndrome, although that's difficult to classify in and of itself, or other specific causes that you can say this is definitely what it's due to. And then it's accompanied by soft tissue fibrosis that wasn't there before surgery. And then they break it up into kind of early versus late stage, as well as severity, mild, moderate, and severe, with like severe problems usually being like less than 70 degrees of flexion, where mild's more like less than 100 degrees of flexion, and extension is kind of like mild would be 5 to 10 degrees of deficit, and severe would be more like a 20-degree flexion contracture.
So it sounds like a spectrum diagnosis, that there's some severity, some less severity, but you'll see variability between patients.
Yeah, and you know, there's been some really cool work in this area, like, and we're starting to learn a lot more about. There definitely is, you know, I'll talk about this as we go through this interview here today. There's a lot of subtypes of this patient population. And so I think differential diagnosis is one of the greatest needs in this area. Like, how do we actually correctly identify patients? Because I think there's treatments that can work really well, but we have to start with identifying the right buckets, if you would. And there's been a lot of comparison of this condition to frozen shoulder or adhesive capsulitis, in terms of, we know it's coupled with a really intense, in some individuals, really intense immune response that then goes on to drive this fibroblastic activity where you get the intense scar tissue. And in the early phases, you know, of a freezing frozen shoulder, we know that being aggressive with those individuals can really backfire on you. And we actually recommend more gentle techniques. If you read the most recent CPGs, you know, like teaching people how to do some nice, easy, pain-free range of motion, and to wait till that joint really kind of cools down and goes through that inflammatory process. And then more in the late stages, hey, that's where we can start to work with these individuals. And we're starting to see a lot of parallels between research in that area and into total knee arthroplasty as well too, for the arthrofibrotic patients as well too, which I think is interesting.
That's really good stuff. And I can't wait until later when we actually talk about the treatment to give perspective to the listeners on what it should look like. I want to talk about your study design, because some people may not be familiar with the feasibility study. I've written several grants on these that I've never got funded, but do you mind describing what a feasibility study is and why you chose that one?
Yeah, you notice I said this was an unfunded trial as well too. It is really hard to get feasibility studies funded as well as published too. It's quite a challenge to get this one over the finish line as well too. But feasibility study is essentially, you know, it's an investigation designed to test the feasibility of methods or procedures for later use on a larger scale, right? It's the pre-work I like to think of before the big clinical trial. In the past, I used to do this very informally. Let's get a few people in the clinic and test out this intervention. Hey, it looks pretty good. Let's use that pilot data for an NIH R01 grant. And you know, usually if you have 5-10 people for your preliminary data, that's usually good enough to move you on to a full-blown clinical trial. I've since realized that methodology is probably not in our best interest, and to really spend a lot of time on the pre-work section before you move on to the big trial. And so doing these feasibility and pilot studies enables you to really refine methods prior to moving into a larger scale trial. So you get it right, and we have less kind of like inconclusive trials at the end of the day, I think.
And what did you find feasibility wise? I think you were able to enroll 10 subjects in, I forgot the given time frame, but it was over a year, right?
Yeah, it was about a year. And so this was working with one surgeon who also has a lot of passion in this area, Dr. Jared Fran. He's an author on this paper with me as well too. Fantastic orthopedic surgeon, does, you know, hundreds of joint replacements a year. And so I think within this year time frame, he had done, I think, has made like about 400 joint surgeries, or total knee arthroplasties, I'll be specific. And every single person who came in with less than 100 degrees of flexion at 6 weeks post-op. And there's also some other inclusion criteria, but essentially they're looking pretty stiff at 6 weeks. He offered them to participate in this trial versus getting a manipulation, which was his standard of care at that time point. And so that's about a 2.4% eligibility criteria, right? And I know that was one of your questions coming up here, but in terms of feasibility, it's kind of a major finding in terms of, you know, how feasible is it to enroll patients in a trial like this? And this was the easier trial in terms of, hey, we have this conservative pathway that we'd like to offer you prior to considering this surgical pathway. Would you be interested in that? And participants, 10 out of 10 were like, yeah, if you think it might work, yeah, I'll definitely try something before we go on to something more, like that might have stronger side effects. Like even manipulation, even though it's not an invasive procedure, there are things that can happen, like you can tear your quad tendon, you can have a fracture during that. There are downsides, as well as I can tell you, anyone who's worked with anyone who's gotten manipulation, your knee swells up again, you have a lot of pain, and it feels like you're starting over, and it's incredibly defeating for the patient. And so I really don't like that procedure, given that, just working with my patients, it's not a very satisfactory procedure in some ways. It can turn out good on the other side, but I found it can be pretty rough. And so one of the major feasibility findings was that, hey, we can enroll people, but I do wonder about future trials, like how feasible it will be to enroll people in terms of, if now we're saying, would you like to enroll in a trial where we randomize you to manipulation or getting this conservative pathway? We know that there's some challenges with getting people to agree to do something like that. And I've had some initial feedback from surgeon groups I've approached with the big trial in my hand and saying, hey, what do you think? Would you participate? And they're like, we want another group of just kind of the control group of what happens when you don't treat this condition, because we always do something, and there's very little studies on the natural history. And so we think it should be a 3-arm trial. And I'm like, okay, we'll see how we can get people to enroll into a trial with one of the arms being, we'll do nothing for at least 3 months or something along those lines. And so feasibility wise, had a lot of findings on the enrollment side that we're still working through and looking at. We also, we can talk about the treatment, but as a multimodal approach, what does that mean in this context? I try to publish, and I saw a guide to readers to our open access publication. We have an appendix. I try to be really specific in the methods, or at least as best as I could for this phase of the trial, and how much we standardize things in terms of what did we actually do? What were the real active ingredients here? And so there's really kind of 3 different approaches that we used in this that I think all work together synergistically. One is using the joint active system static progressive splint system. So there's other like companies that make similar products like ERMI or Dynasplint. Use the concept of, hey, we have this splint that can provide a low load, long duration stretch for individuals, as well as, and we can talk a little bit more about different components as you'd like. Then we had an exercise component as well, and then we had a manual therapy component to this trial. And one of the feasibility findings I was really interested in is, hey, we do manual therapy and exercise with these individuals a lot. I'm pretty sure people will tolerate what we're going to do with them. It's twice a week of treatment for 4 weeks. About an hour of time with patients. That seems very feasible. I wasn't too worried about that, but I've used the splints in the past, and I was curious about what people's perceptions would be. Especially the protocol is you use that splint 90 minutes per day, every day a week, right? And that's per direction too. So if you're stiff in flexion, you get 90 minutes of flexion. It's broken up into 3 30-minute bouts. And then if you have extension deficits as well too, which we did have a few individuals in this trial that did, then you work on your extension and you alternate between the two. So that's 3 hours a day in the splint. And so you have to wonder, what are patients going to think about that? And so I did spend a little bit of time like talking to patients about that particular component of our trial. And we do report a little bit of satisfaction data on that, as well as adherence data associated with that specific component, because I was a little concerned of how that might be perceived and go with patients.
But I think you found that they were pretty satisfied with the splint, right?
Yeah, and that was surprising to me as well too. I tried to do some of these methods without the splint. Like it's clearly like, okay, so what is it? It's basically you have 2 custom molded pieces, one on the thigh, one on the leg, and a tower in between that just has a ratchet system. It's a very simple contraption, but it's big and it's cumbersome and it costs a lot of money and takes a lot of time to get set up. And so you have to wonder, well, can I just give a patient a weight to put over their knee and position them? And that's pretty similar. And I would say, yeah, it is, as well as you can teach people to position themselves in flexion and do like a low load long flexion stretch. And so I kind of wondered about, and that's actually what I did with individuals in the very beginning, because it takes about a week to get your splint, because you have to measure it and send it off and get insurance to prove it. And there's a lot of little logistical barriers that I had to learn about to try and actually do this in a short time frame, because you get the call and it's like, hey, this person's 6 weeks post, they're not doing well, I want to manipulate them. Let's see if we can make some progress. And if you waste 2 weeks getting your splint, like you burned half your time, right? And so you gotta really work out your efficiencies there. But people were pretty satisfied. And I'd ask them about that. And they're like, yeah, it's like, I definitely felt it's definitely doing something, and it gives you really fine control. The little ratchet system, you can like back off by like 1%. as opposed to when you use a weight or using your body to position yourself. I find the changes are more gross, and oftentimes that's harder for patients to control sometimes. And so they're more likely to have a pain response, which is something we really emphasized not having in this trial. You should feel a light pull, not increasing pain. And so, because a lot of people will push too hard, and the splint allows them to really fine tune the amount of stretch that they feel at that time of day is appropriate. As well as a lot of them would say, hey, it really forced me to do it. Like like once you put that thing on, it's a process to get it on and get in there. It's like, okay, if you're there, you're going to do it. And so it kind of, they would speak to it, not only, perceiving it to be effective, but also like, yeah, it definitely would force them to be maybe a little bit longer if they're just positioning themselves and doing a body weight type of stretch.
Mike, tell us about the manual therapy approach. I mean, you've already kind of mentioned that you don't do anything really forceful, that you're not doing what kind of the archaic approach that has been used before, but can you walk us through that?
Yeah. So, I mean, I have a strong training in Maitland approaches, and irritability is something, we're taught first and foremost, like, what is this patient pain dominant or stiffness dominant? How irritable are they? Your SINS signs. And for some reason, I don't know what happens. I think there's a little bit of disconnect, because I think therapists feel pressure for their patient to get them more range of motion, because they have the surgeon being like, hey, you got to get them range of motion, who's their referral source. So there's kind of this power structure that's set up in some ways. I want to please the surgeon, so I'm going to push really hard, as well as my patients. Like, yeah, my knee is just super stiff, and like you feel this pressure, like, I got to get you range, and I'll just try harder, right? And that's not the approach. I found, like, that's not what we learn, but I think there's those pressures that are going on us, and so that's why I think sometimes we put that learning aside. But so the approach we use here is, test retest. So we had a system, like, so it's like, okay, so there's, let's like, if we're talking about flexion, so we kind of came up with two protocols, one for flexion, one for extension. In terms of flexion, I'd say, okay, first, let's do some soft tissue to the quadriceps and see if there's any kind of major trigger points or kind of restrictions or pain generators within that area, right, that the patient perceives that's part of their pain. Let's work on those areas. Then we'll move into the patellofemoral joint, assess any restrictions there. And each step assessing, like, hey, does this improve your pain or does this improve your range of motion? If it does, it becomes part of your core treatment. But we're not going to just sit down and do, like, I'm going to do 12 techniques. This is also something I see you in TK. So I'm going to spend 15, 20 minutes working on with you with manual therapy, but I never check to see which technique is actually helping you and making progress, which I think is really interesting. It's like, we learn this, but we just kind of get in this like rhythm, I think, with total knees, like, hey, these techniques work, I'll just do them. I know we're going to see that. But I find that certain techniques are oftentimes much more powerful for certain patients, right? And you should go through that methodical process. And so we just kind of had like a general recommended battery. So we do the patellofemoral joint next, assessing any restrictions there, and then tibiofemoral after that. I think it's nice to get kind of the soft tissues and the patellofemoral joint moving well first, because oftentimes it's where a lot of tissue restrictions and or pain generators are located. And so if you can do that first, also assessing what techniques work, and then move into the tibiofemoral joint after that. I like that kind of series together, but establishing what techniques. And we had like kind of standard techniques to try first, as well as like different variations that you might see in the manual therapy world that are maybe less common, that would be like effective for the individual, but I still kind of had them as, hey, if this is not working, maybe try a little bit varus or valgus stress with your tibiofemoral mobilization and or rotation as well too. And then what we do is, so you do test retest along the way to see how that helps the individual. And that's useful for you as a therapist in your subsequent sessions, but also you then use that information, right, to guide their home exercise program. Like, hey, if a little bit of varus stress with your flexion helped and decreased your pain, you got a little deeper, hey, let's modify your stretch at home where you're doing that to add that component in, right? So there's kind of this nice integration of like the manual therapy is helping to inform what you're going to do at your home exercise program. Or, hey, we got a lot of change out of doing some inferior patella mobilizations. Let me teach you how to do that at home as well too. If you could teach a patient to do any of this stuff, it went into their whole program as well too. Like soft tissue, it's really easy to do soft tissue on your own thigh, right? And so, hey, you do have some pretty strong trigger points here. It does seem to be, if we address those, that it reduces your pain and you feel more free of movement. Let's start to put that in your program and see if we can help that to be less of an issue for you. And that's often the case.
That's really good to hear. I know that historically, a lot of clinicians have been hesitant to do manual therapy with joint replacements. And I think that's rooted in historical context, that we've changed the joint, so I can't do any of these joint-based techniques. But, I love hearing you walk through your rationale and how you change up your treatment. It's not one size fits all. So good on you on that. Let me ask you this. I mean, you were able to see 10 patients with arthroplasmosis, which, you and I were discussing. If you see 2 in your life, that's probably a lot. Did you change your thought process after seeing those patients and being part of this trial compared to where you were before? I know you've seen hundreds upon hundreds of knee replacements. Did anything change along the way?
Yeah, I definitely gained a lot of nuance. I think in terms of like, where do I think the classifications of individuals are? I think from what I've seen, as well as, since I've completed this trial as well too, surgeons will still send me individuals who are like struggling in this particular way because they're like, hey, you've had some success in the past. And I've met new challenges, as well as, thought processes and evidence on this topic continues to grow and evolve as well too. So my thoughts have changed over time as well too. But I know when I kind of went into this, I was like, well, I do think you have a couple different like flavors of individuals. Like some people might have more swelling, more pain. You have some different variations how you should manage this. Before each, so it was really interesting because each one of these people, I'd sit down at the beginning of the trial for the enrollment process, and I'd just say, well, tell me about what your past PT has been like. And a large number of these, and I'd be like, in particular, I'm like, what they tell you about your range of motion, your struggles, as well as what do you do at home right now and in PT to actually work on this. And there's a fair number of individuals that just didn't have a structured plan. It's like, well, I do this on the stairs. I'm like, okay, how much do you do that? How often? It's like, oh, I do it once a day, 10 reps. I'm like, you stretch your knee 10 reps once a day and you have stiffness? I'm like, we're going to need to dramatically up that, right? And so my protocol, it's like hourly movement, like through your pain-free range of motion, and then you're working on low, long duration stretching, frequently throughout the day, building up, hour and a half plus of time working on low, long duration stretching. So a very specific protocol, as well as some flexibility to address any two joint muscles that might also have some play into your stiffness as well too, right? So those are kind of core exercise programs. And like a lot of people, like they didn't have any, they might have a handout, like 20 handouts. In fact, like here's some I got from surgery and here's what I got my PT. And I'm like, well, what's your program? It's like, I just kind of do this. And they kind of put together their own program that obviously is being highly unsuccessful for them. And so like, they just needed a structured program that with some accountability, and they did great. Like and I can talk a little bit more about responders as well too. Like they'd also be the ones that are mostly stiffness dominant. They might have a little bit of pain, but for the most part, they're like, yeah, it feels really good when you mobilize my knee. I feel so much better afterwards. And you gain like 5 to 10 degrees easy within a session, right? So and you like all those people went on to do really well in this trial for sure. Yeah. Then there's like, we had a couple of people that are overdoers, like, so either due to their occupation or their kind of exercise program that were just pushing their knee way too hard, too fast, and they're getting a ton of swelling and pain rebound. And they just weren't, their therapist and or them or as a team, they just weren't reading the signs like, hey, you need to back off on what you're doing, right? And there's a couple of people, one, you're able to successfully back him down. And that a lot of that was due to his occupation. We came up with some strategies. And as soon as he got his activity levels under control and had a little bit more focus on how he was working, he came along nicely. The other individual, he was one of the ones that went on to get a manipulation. He just had this like 3 to 5 hour program every day that he'd do, and he was doing a ton of stuff. And yeah, I think that worked against him a little bit in terms of not listening to his body. And then we had a couple of people, interestingly, that had prior TKs on the other side that they needed manipulations for, which I thought was really interesting. You have this history of needing a manipulation on your other side. There has been talk about definitely genetic components to people who might be at risk for this. As well as since then, I've seen some people that I really think there's some sort of dysregulated inflammatory process that's going on as well. We didn't have too many of those. I would say actually none of the people I would fall into that camp in this trial. I've since seen people because of this trial that I really kind of put them into, they have like a very strong inflammatory response. And the strategy that the surgeon I work with uses now, he just basically says, stop beating up the knee, don't go to PT, just take like 9 months off. We're going to cool you down. Don't do anything. Just do ADLs, basic things, and then let the joint cool down. And then we're going to go in there, and he does a scope and cleans out a ton of scar tissue, and then they kind of restart. But the idea being that, the scope, you can be a little bit more precise in what you do, as well as hopefully that acute, really dysregulated inflammatory process is calmed down. So you can kind of think that in the frozen shoulder world of like, hey, they're in the thawing stage at that time point, and the surgery is in there to try and help bring along the knee process, but you want to get them through the freezing phase. So I kind of see these like little buckets of individuals along the way in terms of, how I approach that condition. I definitely didn't have that level of nuance going into this trial, that's for sure.
That's super interesting. Just briefly tell us, how did your group of 10 do against your historical control of manipulation under anesthesia?
Yeah, so this is really interesting, so it's the same surgeon, and so these are all his patients. He's like, fellowship trained out of Rush. He's a really good surgeon, but still 1% to 2% of his patients, go on to develop this, which would be pretty typical, right? And so we had a historical cohort, really the 4 years prior to us starting the trial, that we look back and look at the range of motion, both preoperatively and intraoperatively, because those are part of our inclusion-exclusion criteria, and came up with this group of about 30 individuals that had manipulation. We followed them over time. So that's retrospective data that we had. And then, for the patients who came into our group, so 7 out of 10 were able to avoid manipulation. And we defined success in this trial because the average range of motion coming into the trial at 6 weeks post-op was 90 degrees, which you'd say is stiff at that time point for most people, because a lot of them, the average pre-op range of motion was 130. So these people didn't have pre-op stiffness, which is kind of a different category as well. But they're able to gain, on average about 27 degrees in 4 weeks. Like this, that's pretty fast. And so they're like ended up with about 117 in terms of average. I think, and then what's interesting, we followed them long-term, so about a year out, and they had about a 35 degrees. So they were able to kind of continue a little bit of gain into the future as well too. So they gained about 35 degrees, ended up with what we as PTs would typically say is a good TKA knee outcome, which is about 120 to 130 degrees. So 7 out of 10 people were able to get into that. Some of them also had extension deficits as well too, and that was able to improve from 13 degrees to about 5 degrees or so overall. So
yeah, I actually think I was impressed by that, and I think the numbers were comparative to the historical control too, which is, I think, impressive.
Yeah, so it's really interesting. Yeah, so manipulation in these groups, in terms of when we looked at them, kind of a month out, right? We're right on top of each other, actually. I mean, so this isn't powered. Like, that's one thing you always have to know about a feasibility trial. Is this powered for statistical significance and clinically meaningful differences? Absolutely not. The confidence intervals around this are still pretty big. That's why I'd want to do a bigger trial to more definitively say, rule out any clinically meaningful differences between groups. But right now, the means at like the standard post-op time point, about a month, are right on top of each other. And what was interesting, at about a year out or so, that's where you actually see our MPT group, as we called it, our multimodal physical therapy group, actually had on average better range of motion than the MUA group, which I attribute to maybe they didn't have to have the trauma of the manipulation, which might do some of its own effects, as well as they also learned how to work on the range of motion conservatively. There's a big home program emphasized. And so the fact that they're done with the trial, and formally being in PT when the splint, doesn't mean they didn't have the knowledge now of how to continue to work on the range of motion independently as well too. So maybe there's some carryover there as well too. But I thought the long-term results were particularly interesting.
Yeah, I like that learned aspect of it. I think that probably does carry over. Hey, as we wrap up here, what are you most proud of from this study?
All right, what am I most proud of? I'd say helping the individuals who are in the trial. This is a really frustrating condition, and they were so grateful and thankful to have the opportunity to participate. And I was just really happy that we were able to get a majority of it. And the ones that ended up going into MUA, they ended up doing fine as well too, right? Just a little bit longer road to get there. So I was really happy for helping these people. I was really kind of, and I'm also really proud of getting this trial out as well too. I'd say is a big hurdle to get this published. And I really think we need a lot more thought process and the clinical reasoning surrounding how do we approach some of these more challenging conditions. And I think this is a good step in that direction. Definitely not a definitive one, but at least a good step in the right direction. So I'm pretty proud of that.
Well, I think it's a good step, which is why I asked you to talk about it, because it is one of the most challenging conditions to treat. I, again, seeing my father suffer through this and then other patients in the past. So I appreciate the fact that you're doing that. If you had a minute to do an elevator talk to, the heads of the Orthopedic Society, what would you focus on? And I know this is a feasibility study, but what would you say?
Yeah, I mean, I would say kind of coming full circle in our conversation, I think differential diagnosis, like how do we actually start to classify these individuals is really key, because we need to do a better job of differentiating these individuals, because there's quite a few that go on to have manipulation, and that fails, and then there's need for revision or subsequent procedures, or a failed knee replacement just in general. And so I think we need to do a better job of differentially diagnosing reasons for stiffness after surgery. I do think that conservative methods do hold potential for a potentially lower cost and less risk alternative to manipulation, and may provide better outcomes. I think we also need to look at additional treatment approaches that are beyond surgery and conservative care that might also need to consider, like pharmacological processes maybe that could help to address some of the immune processes we're seeing as well too. So thinking outside of just surgery and PT related methods for this patient population as well, which is not typical at this time point.
My surgical colleagues here at Duke, they're not fond of doing manipulation under anesthesia, so I imagine they're very open to hear, the positives of what you found. Hey, Mike, thanks so much for sharing your work with us, and appreciate you being on here at CMET. And how can people learn more about you? Are you on social media, or if they wanted to reach out and find out more about your work, what would they do?
Yeah. I mean, so we're on Twitter, LinkedIn, Facebook. So like at Restore Team, Restore_team is our Twitter handle. So feel free to reach out that way. Also, feel free to come by movementforeveryone.com. That's our lab's website as well too. So that's a good resource to get a hold of us and learn a little bit more about what our group's doing as well too.
Thanks again, Mike.
Hey, appreciate it. Thank you.